Hello and welcome back to Ben Coomber Radio. So here you are again with me, Tom Bainbridge, the usual co-host. But I've been given the really fortunate privilege to introduce someone who's got some fairly important credentials, I think. But I've got the pleasure of being here with Dr. Jordan Feigenbaum. He is I believe, the owner of Barbell Medicine. Is that correct?
Yes, sir.
The OG of Barbell Medicine, but Jordan, I'd just like to introduce you. Please let the listeners know who you are and a little bit of backstory.
Sure, yeah. Thanks for having me. So my name's Jordan Feigenbaum. I started Barbell Medicine in 2011, and since then have been doing that. I have, education-wise, I have a bachelor's in biology, a master's degree in anatomy and physiology, and then ended up getting my medical degree from Eastern Virginia Medical School, did my residency at UCLA, and now do barbell medicine-related things full-time. So you can find me on the internet almost all day.
Awesome. Jordan didn't mention it, but you're an elite powerlifter, right?
Oh, yeah, I forgot. Well, because that was like, I still train, obviously, and I still try to, hit PRs. But yeah, so my best total's 1795, which in kilos, I think is like 830 something. I don't know. It was at the time, it was like the 16th best total all time for the 90 kilo class. So I had anyway, but that was 2014. I'm on my way back. But anyway, yeah, that's part of the history too, I guess.
Cool. What made you drop that? Was it just a case of moving into different things, or was it something that you just loved?
No. Yeah, I got bored with powerlifting. I thought I did that. I hit that total during medical school, and I remember after my last deadlift was 725, which I think is it's like 325 kilos or something like that, or 330 kilos, like something like that. Anyway, and so after I pulled it, I was like, I think I'm good with that. Like I mean, and it wasn't that I was like I didn't want to lift any heavier or whatever because I was afraid. The drive to like keep training that way it just decreased. And then again, I was just kind of bored with powerlifting. It's like, okay, go to meet, win meet, and then which, wouldn't have happened at like the world level, but I just had no interest in doing that. And it wasn't available to me either at that time, like qualifying to go to world championships and then leaving the country while I was in medical training. So anyway, a bunch of things conspired. And I ultimately I did CrossFit for like 8 months because I thought, oh yeah, this will be fun. And it wasn't. There was no part of that was enjoyable. It really wasn't. So I'm back in powerlifting now. I've competed a few times since, like I said, it was 2016 where I came back, and then I got another meet coming up in May. The running joke is that I'm just chasing former glory, like 2014 me. I'm trying to get back, but still trying to mix it up with the young kids. So.
Yeah, well, from looking at your Instagram, I don't think you're doing too badly, to be fair.
Right. Getting close.
Yeah, so I think I started following you on Instagram probably about a year and a half ago. So I discovered you through like the convoluted method. So I've always followed, there's an individual, for the listeners who've never heard of him, called Alan Thrall, who's really
nice.
a follow on social media. His YouTube channel is brilliant. It's called Untamed Strength. So I followed Alan for a long time, and then he started getting coached by Dr. Baraki, didn't he?
Right.
And it was through Austin Baraki, again, someone else that you guys should really follow. His Instagram feed's fantastic. It's just videos of him deadlifting ridiculous amounts of weight, and then his Instagram stories are full of like research papers, which is the perfect content for anyone, really.
It's perfect, dude.
And then I just started paying attention to barbell medicine, and I think a good way to sort of launch off on, because there's kind of two topics that I'd really like to talk to you about. What decided the name barbell medicine?
Oh, sure. Well, so there was an article that a former colleague of ours wrote that said barbell training is big medicine, right? And that came out, I think, in early 2011 or maybe early fall. And then when I read that, I had already thought like, hey, you're going to medical school, like combining like resistance training and medicine, that's should be something that you do in some capacity. I didn't know that it was going to grow to what it is now, but in any event, so I was trying to come up with a name for a business anyway. And I was like, barbell training is big medicine, barbell medicine. So that was definitely an influence. I don't know where it actually like, where I didn't wake up one morning in like a cold sweat and say, barbell medicine, or like a meteor didn't hit and then like a cloud of smoke appeared in the shape of barbell medicine. But yeah, so I think between that article and then just the literal combination of strength conditioning and medicine was like, okay, well, resistance training, barbell medicine, that makes sense. And so, I got the business license and the LLC and registered the trademark and everything. And it's funny though. I was dating this girl and I was trying to come up with a tagline. So it was like barbell medicine. We're like, we need a tagline, right? And then in medicine, we have this phrase that describes like research, translational research, which is like something that happens in the lab and then you try to take it to the patient's bedside. And so they call it from bench to bedside. And then I was like, see that would be cool, with you from bench to bedside. And so I remember I told this girl that, and she was a medical student as well. And she goes, that's the dumbest thing I've ever heard. No one's going to like that. People are going to think your business is stupid. She was piling on. I was like, dang, what a savage. But well, we don't date anymore. And obviously she has poor taste. No, so that's, so that all kind of came to fruition in 2011. And then been doing it ever since.
Awesome. So when you say, because one of the things that obviously barbell medicine does stand for is the use of resistance training alongside, you would say, medicine. I think when a lot of people hear that, you would immediately associate, well, barbells and medicine, so that's exercise, so that's going to be helping primarily with obesity, fat loss, and all of the associated metabolic things that go along with that. But you guys take a slightly different tack as well. Is that right?
Yeah. So the way we view it is that you exercise and resistance training as a part of that, in addition to other lifestyle modifications that are kind of always lumped together and given, lip service in the medical literature, like nutrition and sleep modification and, stuff like that. They can be used as primary prevention, so preventing something from before it ever occurs, or secondary prevention, preventing something from either getting worse or happening again. And this could be things like, cardiovascular disease or cardiovascular event, could be diabetes, could be high blood pressure, et cetera. So our job was that we felt like compelled, or where there was a big hole, was while there is this overarching or sort of like this theme in medicine to always recommend lifestyle modifications, there was nobody really delivering that to the strength training world, like saying that, hey, we're doing this, like we want to do this, you help us, like bridging that gap. And then similarly in medicine, no one was bringing like legitimate training, either programming or program design or actual, how to physically get somebody to move, but nobody's bringing that to medicine. Mm-hmm. So we felt like, all right, we were, I'd been coaching already for a ton of years, for a long time. And I was in medical school, so I was becoming a medical professional. So I was like, who better to bridge that gap than, someone like me? And then luckily I met Austin, and we kind of just ended up doing this together, and it keeps growing. So yeah, we think that we can have a really big impact at multiple different levels in a public health perspective. The performance thing, with competitive athletes, like we both train, high level lifters and the high level athletes, that's more fun than anything else. And I think those people are just looking for guidance and management rather than like medical care. Yeah. Because, they want to know like, hey, I've got this shoulder thing. What do you think? All right, sure. But we're not like, I think people assume that we're, asking our clients to like go get blood work like every other week. And we're like making training based decisions on some like wackadoo algorithm that we've like come up with, like, oh, well, if your serum testosterone cortisol level is this, we have to do this with training. Like, no, that's all BS anyway. And we're not in the business of like just swindling money from people. So we don't do that. But, Well, yeah, we're more concerned with like legitimate coaching practices, and so we do that, sure, with some athletes, but our bread and butter is general population, public health sort of stuff.
Perfect, perfect. One of the main messages that I do pick up from your guys' content is sort of around pain and the misunderstandings that a lot of people have around that topic. So there's kind of a lead in that will give a bit of context. One of the words that you guys mention quite a lot is biopsychosocial.
Sure.
I think it would be good. Can you give the listeners at home sort of a 3,000-foot view of what that actually is?
Yeah. So in medicine prior to like the 70s, and then, this has taken hold even more recently, we previously used to think of pain and other medical diseases as just a biomedical model, meaning that there was something structurally or anatomically wrong in the context of pain, and that's why you had pain. So if you had knee pain, there was something wrong in the joint, and that's why you had knee pain, and you had to fix that. That's a very simplistic view, but that's kind of what we were working with until this introduction of the biopsychosocial model, which was first described in the 70s and really kind of has taken hold since the 90s. And this is like the prevailing, idea of how all diseases are not only like how people experience their symptoms, like the lens through which people experience their symptoms, but how you end up having to manage and treat their symptoms and the underlying pathology. So we call it the biopsychosocial model, which means that there are three sort of pillars to the disease experience. There's a biological pillar, there's a psychological pillar, and then there's a social pillar. And you can think of this as like a pie chart. And so the sum of all three parts adds up to 100%. In the context of pain, some pain is going to have a greater, influence from biology. If you have a compound fracture, bone sticking out, there's a huge biological component to your pain experience, right? If you have nonspecific low back pain, which is the most common cause of low back pain, you have a very small biological component, and rather the psychosocial influences on your pain experience ultimately dictate, they kind of amplify or diminish that biological signal based on peer-to-peer learning. So for instance, if you hold somebody with a high level of regard, and they tell you that if you have this, minor low back pain, that it is a sign of like this severely herniated disc, and that starts to freak you out. And so then your psychology is, working against you, you will likely have a more significant, as far as intensity, and then longer duration of pain than if you did not have had that experience, right? So basically, it is a way to better describe how people experience pain. You can give people the same sort of stimulus, we call it nociceptive stimulus, that could be interpreted as pain, but you give them the same sort of like biological input, and you'll have massively different outcomes. And that sort of amplifier or diminisher is due to the psychosocial components. Cool. That's just how we understand pain. And this isn't our model. We didn't come up with this. This is just if you look at pain science and you read this literature, which has been emerging in lockstep with understanding of stress and fatigue and the sort of neurohormonal, neurophysiological sort of functions of the brain, like you'll see this all has parallel together. So the more we learn and have learned about the brain, in basic terms, the more we learn about this actual model. Before, we were just ignorant to all these different functions of the brain. And now that we know more, we have to expand our model to include those new things. And I think 20, 30 years from now, we're going to know even more about the brain. And I don't think that the biopsychosocial model will be like repealed and replaced. I don't think that's what's going to happen. It's just going to be expanded. We'll just know more how to influence each of those different pillars and affect, how that ultimately modifies our pain experience.
Brilliant. Yeah. No, I mean, I remember learning about the biopsychosocial model in my undergrad. So it's not something that's like hidden knowledge that you guys have discovered. But I do think it's something that's missing a lot from the fitness conversation. And I thought one of the things that you brought up there, so especially non-specific back pain, like I think that would be worth exploring. So the standard, I mean, my girlfriend suffers with non-specific low back pain. Sure. And the messages that she's received can be probably summed up as she has a degenerative disc,
Sure.
which I think would be cool to get you to talk around a little bit, because I've read into that a bit. Or she's got some specific muscular weakness. It's usually either she's got a weak core, or she has a weak low back, or there's something wrong with the piriformis. And what I've been reading is that that's not necessarily the best message to be given.
Sure. Yeah. I also like that you bring your girlfriend's back pain into this. Like, you're like, hey, what I'm going to do is get this guy on the podcast and he will fix your back. I want
Yeah. So when you get home, just listen to this.
Right. Yeah. I think that the way that we say things is very important. Because it builds this narrative that the patient, in this case, ends up identifying with and like absorbs and makes their own. So for instance, if you came in and I told you that you had, multiple herniations in your back at, 3 different levels, and that, evidence of degenerative disc disease, which that's not an unusual finding in an asymptomatic patient, meaning that if you MRI'd 1,000 people's backs and they were, over the age of 30, for instance, you're going to have a significant percentage of those folks who have at least one herniated disc or evidence of degenerative disc. And in fact, there's been a push in the radiology sort of field to, instead of labeling it degenerative disc or like something disc disease, to say age-appropriate changes in the disc, because that's usually, unless it's something that's not age appropriate, in which case you should point out that pathology. So in any event, the narrative matters, because then people will start to think, okay, well, if I have this disc thing and that's the source of my pain, that is the pain generator, then I must fix this thing in order to get better. Mm-hmm. Which, now it is true that herniated discs, especially the worse that they're herniated, they have a very high chance of like reabsorbing, healing on their own with time. I think it's like, I don't have the papers right in front of me, but it's something like 80% or higher of like severe herniations will reabsorb within the next 6 to 12 months, something like that. Wow. Yeah, right. And he's like, oh, okay, cool. Well, the body's adaptable. We're resilient humans, like whatever. So, but if somebody has this narrative where this is the thing that's causing your pain, and until that is fixed, you won't feel better, they're going to have worse outcomes. They're going to have pain for longer. The duration that they have pain, there's going to be marked by reduced function, because again, they got to fix this thing. And whereas our narrative would say, you have back pain, we're not necessarily sure why, but because you don't have any of these like very scary red flag symptoms, like you've lost control of your bowel and bladder, like you have, foot drop, or like these other like somewhat reliable neurological signs that indicate like you should see a spine specialist right now, or at least soon, then we think the source of your pain is unlikely to be something mechanical.
Okay.
At least it's not significant enough to be the overwhelming, like the big part of the pie chart. Right? There may be a little something in there, but not only can we not identify reliably what it is, which is true across the board. For instance, if you give the same MRI to 10 different radiologists, you're going to get 10 different reads. They won't agree on like if there's a herniation, where the herniation is, or whatever. So we wouldn't be able to tell you what the biological cause is or what the biological sort of insult is reliably. And so since we can't do that, we can't manage that. And so some practitioners will say, well, you just need a higher level of training. It has to be my hands or my diagnostic thing. But we can't, the chiropractors, acupuncturists, massage therapists, physical therapists, like you name the specialty, or like spine surgeons, orthopedic residents, internal medicine doctor, like you name the profession, and they have been humiliated in these tests where they're trying to identify like where is the lesion on it, like where is the insult, where is the problem, can you palpate it? No. Can you identify it reliably on imaging? Not really, unless it's something very, very severe that does require management. So anyway, in a non-specific low back pain like this thing, you would say the biological insult is likely small. And what's more, though, the experience that she's having, the pain, is obviously been amplified by her understanding of what happened. Like, so for instance, she might have been deadlifting, for instance, and then that has been conditioned into her over the years that deadlifting is maybe risky for the back, even though she doesn't talk about it at parties and she won't, admit it. But like in our culture, that's been said. And so she's like, I was deadlifting and then I felt a pop. And she's like, and then that pop, whether she admits it or not, the pop is worrisome, and she thinks, oh gosh, I must have done something bad this time, I'll never be able to lift again. And so again, you have this anxiety component, you have this fear component, you have this what's my previous understanding of what these things mean component. Oh, my dad had back pain, I've got social learning that suggests that this is bad news. My peer-to-peer learning by people I see on Instagram who tell me that back pain like this is due to tight muscles or imbalances, and I've really done myself in this time. So all of those things kind of magnify that biological component, making the pain experience or the output of the brain much more intense. If you contrast that to somebody who doesn't think that way, I'm not saying that your girlfriend does or doesn't think that way, by the way. I want to make sure that you're not single at the end of this broadcast. But so if you have somebody who doesn't necessarily think those things, then that same biological input is viewed through like this neutral filter, and they don't have a pain experience. They're just like, I'm fine. So I guess to answer your questions, for non-specific low back pain, this is not a belief-based sort of question. These aren't belief-based questions, meaning that when somebody says, well, I believe, then immediately you just say, hey man, it's not about your beliefs. This isn't a religious deal. This is evidence-based. Let's use the evidence. So for non-specific low back pain, in general, there are not low back pathologies that we can identify either by palpation or imaging or physical examination that reliably cause pain that don't also co-present with large neurological deficits. Like, oh, I was in a car accident, literally part of your spine has like moved a significant amount apart and like you're paralyzed right now, or you have foot drop, or you have bowel bladder loss of function. Okay, so for instance, if you say you have low back pain, we cannot reliably identify the cause of that through MRI, CT, X-ray, physical examination, somebody touching you and say, oh, I feel a knot. Like we can't, that's not something that occurs. We also don't have evidence that a weak muscle in general contributes to this, meaning that, so there's a study looking at powerlifters, or people who are, sorry, not powerlifters, resistance trained individuals versus untrained individuals. And the first thing that was funny is that the incidence of low back pain was not necessarily different between the two. Like, so you would expect, oh, well, the stronger people would have, on one hand, you might expect if being stronger helped, then you would expect the stronger people to have less instances of low back pain. If you're on the other side, you say, oh, resistance training is bad, like it's dangerous, then you would expect the resistance trained folks to have higher incidence of low back pain, but you don't see either. It's the same. So there's no difference. Then they tried to test how long that they could actually hold. It was like a certain degree off one of those 45-degree like back extension benches. And there was no difference between the resistance trained folks and the untrained folks, suggesting that they might not even have stronger muscles in that specific position, which kind of makes sense, right? Like, so strength is specific to like range of motion, joint joint angles, muscle lengths, contraction type, etc. So it's like, okay, if you don't train this, then I don't know that you're going to be stronger. So in any event, that was another kind of funny thing. But yeah, we've only identified that people who are deconditioned and who do not regularly engage in exercise tend to go to the doctor more often for pain. And that's just like as a general rule. So when we talk about like injury prevention, for instance, there are only like two main sources of this, two main like sort of final common pathways, and anything that feeds into one of these pathways ends up being like fairly beneficial. So one is actually getting stronger. So anything that improves your ability to like produce force kind of bolsters you against getting injured because it improves your ability to deal with physical stress effectively. Yeah. And then load management is the other one. Load management, meaning that your acute workload doesn't exceed what you've previously done by too much. So we call it your acute on chronic workload. So for instance, if you've only ever done 5 sets of 5, 4 days a week, and now all of a sudden you do double days of 5 sets of 5 in the morning and the night, so now it's at 8 sessions and you literally doubled everything, your acute on chronic workload may be too much. And that can cause people to have injury and subsequent pain. But we haven't identified like specific muscles or specific like muscle weakness in general to be a predictor of like non-specific low back pain. That being said, somebody in the audience right now or the listening audience is saying, yeah, well, there's like all these studies that if you exercise and you have low back pain, the back pain gets better. It's like, exactly, it's true. You're effectively conditioning the person to not have back pain. So for instance, your girlfriend has low back pain right now. One of my first things after making sure that she doesn't have anything that kind of worries me, like, I don't feel comfortable like even talking to you right now, would be, what can she tolerate right now? So if deadlifts, for instance, from the floor were too much, maybe it's deadlifts from blocks. And if deadlifts from blocks doesn't work, maybe it's sumo deadlifts. If that doesn't work, maybe it's from blocks from above the knee. And if that doesn't work, then all right, maybe it's hip thrusts or maybe it's some type of squat or whatever. I'm trying to get her to do something that proves to her that not only trains like the muscle groups that we're like looking to do and kind of at least somehow tangentially relates to the movement that we're trying to train, but also that proves to her, hey, I'm not fragile. I'm a resilient human being. I'm an independent woman, that's the whole thing. And so it's like this Bayesian sort of prediction where like, if you think that you have back pain, it's real, real bad, then you will be hyper vigilant. Like let's say you hurt your back on a deadlift. So you're setting up on a deadlift and you're like worried. You're like, is it going to hurt this time? You're hyper vigilant, which increases your chance of having. And so you're like, but then you do the weight and there's no pain. You're like, oh, maybe I'm fine, right? Maybe you're still a little gun shy. You're not 100%, because once you go past a certain weight, you actually do feel it. And you're like, oh no, I knew it. I knew I wasn't ready to go. And so you're just trying to use movement to like prove to somebody like, hey, you're actually fine. And so the worst thing that we can do in these situations is avoid exercise, avoid movement. Because in fact, you're not able to sort of convince the person like, hey, you're actually fine. So that's to answer your question about the muscle imbalance, like, and how like training kind of helps post hoc, like that's really the mechanism that we think there. And then as far as a flexibility deal, there's no data associated with specific range of motion measurements that will rely on incidence, intensity, or anything related to low back pain, meaning that you couldn't go 1,000 people, measure their amount of hip flexion or hip extension or like anterior pelvic tilt or posterior pelvic, like you couldn't measure that reliably, like probably anyway, some of the studies on that are not very good, like actually just trying to measure it in general, but you couldn't measure them, have a cutoff and say, yeah, if you have it above this, you're going to have pain. Like you're at greater risk of injury. This is the same deal with the functional movement screen, the FMS. It's like, sure, yeah, it's got a high degree of like sensitivity, but its specificity is super low. So it's not a useful test then.
Can you just expand upon that a little for people who are not aware of it?
So yeah, these are statistical terms to effectively mean like you want a test that's both sensitive and specific. So something that is sensitive enough to pick up everybody who's got like a potential to like have a bad outcome. So in this case, that you want the functional movement screen, functional medicine screen. That'd be funny. You want the people in the functional movement screen. You want to identify all of those who are at higher risk of injury. So it does a pretty good job doing that. Just because, and I would argue that's because it's not discrete. Like since it's not specific enough. Yeah, you just pick up everybody.
Yeah.
So of course, yeah, great. It's got good sensitivity, but it's not specific in that it actually predicts people who are not going to have like it doesn't differentiate between people who will and will not have an injury. So it gets everybody who's like going to have an injury, because, you know, injuries happen in sport, injuries happen in life, but it doesn't discriminate between people who actually aren't.
Yeah.
So you want a test that picks up all the people who are going to have it, sensitivity, and you don't want it to pick up people who aren't going to have it, which is specificity. So a better, maybe easier to understand example has to do with obesity, for instance, right? So if you were going to use a BMI cutoff just to describe people who are obese, if you set the cutoff at 20, a BMI of 20, right now it's 30 for obesity, but if you set it lower, you will get all of the obese people in there, because you set the bar so low. But you're also going to get a large amount of people who aren't actually obese. And so that cutoff isn't very specific. It's very sensitive. It gets all of the obese people, but it doesn't tell you reliably if somebody who's got a BMI over 20 is actually obese, because you're getting all those people from 20 to 30. So that's kind of the story of the test. We really went off on a tangent there. I feel like whoever is editing this in post-production is just gonna...
Nothing gets edited. No, this is, that was all really good. I think with that as well, the functional movement screen, I see a lot of fitness professionals will use that or something similar. So you'll do some sort of movement screening thing.
Sure.
And a lot of PTs will say, okay, well, this movement's good, this movement's good. This one isn't necessarily good, so we can't do those exercises yet. And the reason that they give is because you'll injure yourself. So, full face there.
That's just my face. Sorry, I had a stroke. What happened?
So I'm guessing alongside with what you've just said that that's not the right message to be given, right?
Yeah, and okay, so the idea, this again goes back to like belief-based versus evidence-based sort of, you know, question answering. So if you're trying to screen people for their ability to engage in particular exercises, people would be, you want somebody to squat. You want somebody to be able to do a squat. And so you're trying to figure out what movement or what screening tool can you use that would tell you if they can squat or not, besides the squat, obviously, which would tell you with 100% sensitivity and 100% specificity that a person can or cannot squat, right? Yeah. So some trainers and physical therapists, et cetera, will use a test where like the person gets down on one knee with their foot like 6 inches from a wall and try to touch their knee to the wall to try to see if they have enough dorsiflexion in the ankle to tolerate a squat. Mm-hmm. If that test reliably carried over to squatting, meaning that if someone failed that test, they reliably couldn't squat, then you could make the argument that it's an okay screening tool if it affected your management and was reliable, but it's not. We have evidence on this. Like if someone says, yeah, well, I believe, I don't care what you believe. I say it like that in an aggressive way, but it's like, this is not a space for your beliefs. Like if you are in a position of authority and you're messing with other people's lives, you're guiding other people's lives in some way or another, then you have to rely on the evidence where it exists. Where the evidence doesn't exist, and you try to use similar data and experience to kind of come up with hypotheses, and then you wait until more evidence comes out. These particular cases, we don't have any screening tools that reliably predict whether someone can or cannot do an exercise that's not that exercise. So the best screening tool for if someone can squat or not is a type of squat. It doesn't mean that a person who's never been in your gym before comes in and instead of you assessing their ability to do a body weight squat or assisted squat while they hold on to something or whatever, that you put them under a barbell and say, cool, well, we're going to start with the low bar back squat. Let's go. That's not, that just means you're a bad coach. Okay. Yeah. Like you don't understand how this works, but there's no test that I can do outside of some form of squat that tells me with enough reliability that someone can squat or not. Same thing on the bench press. There's nothing I can do. Like even if somebody couldn't do a push-up, full range of motion, that doesn't tell me if they can bench or not reliably enough. Yeah. Same thing on a deadlift. Like what am I doing on a deadlift? Like, oh, well, you didn't pass the hip hinge test with the PVC pipe. And it's like, Yeah, that's again not reliable enough to deadlift unless what you're saying is you tried to have them deadlift with a PVC pipe and they couldn't do it.
Mhm.
But in that case, you're looking at, do these failed tests predict risk of injury? And
Yeah.
the answer is no, they don't. This is the same argument we have on the internet all the time when people talk about rounded back deadlifting being like, oh no, that person's gonna blow their back out, and that's so okay. I really don't want to spend like 20 minutes talking.
I've had that argument as well, because I've posted a few deadlift videos and I do have a little bit of spinal flexion.
Yeah, well, so you can't lift it.
Not like
You,
that.
no, you can't. So you can't lift things with your legs without spinal flexion. This has been studied. So again, belief-based versus evidence-based. So in order to recruit the legs and their full like volitional force production capacity, you have to flex your spine. It doesn't mean you go into like flagrant lumbar or thoracic flexion, but there's some flexion that goes on. What's most important for this is that it doesn't appear to be dangerous.
Mhm.
It appears to be a normal variation of human movement if it's been like trained over time, meaning that you've exposed yourself gradually over time as people do in progressively overloaded resistance training. It doesn't appear to be inherently like risky. And what's more is that from an anecdotal standpoint, which is probably the lowest quality evidence, but evidence nonetheless, people get, for instance, low back pain with great deadlift form when they don't deadlift, and sometimes when they deadlift with rounded backs. It happens in all those populations. Maybe it's just that deadlifting doesn't matter really with respect to low back pain outside of contributing to either too much fatigue compared to what somebody can tolerate, or perhaps positively, strength training being preventing injuries. And that's more in sport rather than like pain in everyday life. But it's just you wouldn't be able to predict whether somebody's going to have an injury based on their failing of some made up arbitrary test that again has no scientific validity in this sort of thing. So I would caution those who are doing these things to maybe rethink their position on this, because one, it's a waste of time. You're wasting your training time and your client's training time. Two, it's not helping you manage their training. If someone fails the ankle, knee to wall test, that doesn't tell you what you need to do. You're just going to have them squat, right? Mm-hmm. If the answer to that is no, then I don't know if you should be coaching people. If the answer is yeah, you're going to try to have them squat anyway, then why did you do the test in the first place? It doesn't tell you anything. So just stop doing the test and start squatting earlier. That would be the idea. And so I think that people should probably stop doing that for those two things in mind. And then as a third deal, you really have to, that narrative again comes back around. If I was coaching somebody and I was of the mind to do these like tests before they lift, I tell somebody, ooh, your ankles are tight. Mm-hmm. Ooh, your medial gastrocnemius looks a little tight there. I don't know. Maybe squatting is a bad deal for you. And then, holy shit, they have to squat at some point in their life in the future. Like you may have just set them up for a bad outcome, or at least put that nugget of information in their brain that from peer-to-peer learning, social learning, that makes them do worse. Now, nobody's doing this on purpose. Nobody's being a jerk on purpose. And but words are important, and selecting how we manage our clients in the strength conditioning field, is also important. So I think that it's reasonable to encourage folks to, hey, stop doing this silly BS, and also be careful with your word selection.
Oh, it's brilliant. I guess some of that, what you said there, especially when you were saying that the tests need to be specific and you can't, for example, predict someone's ability to squat by their ability to touch their knee to a wall.
Sure.
That specificity side also I see come in when we're looking at the things people do to warm up before they train.
Sure, yeah.
I see people doing lots of mobility work, activation work, foam rolling, all of these kinds of things. would that sort of fit within the same methodology, or is there something to that?
Yeah, I mean, well, so again,
we're talking broad strokes here.
Yeah. So it's tough. I think, I mean, if you're asking me just, based on my current understanding of the evidence and current stuff's been published, I don't think that there are any pre-exercise warm-up modalities that are uniquely beneficial outside of gradually increasing the intensity that somebody is exercising from a very light, minimal state to higher. And I think that we have decent evidence that practicing the specific skills that are about to be tested and displayed also has some pretty good evidence suggesting that that's the best sort of course of action. We don't have evidence suggesting that foam rolling improves force production. In fact, most of the data suggests that it actually decreases force production or has no effect on force production. We don't have any data suggesting that foam rolling, for instance, increases joint range of motion better than any sort of generalized warm-up. We don't have any evidence suggesting that foam rolling decreases incidence of injury, reduces duration of pain from any particular type of thing like that. Same thing with specific activation drills. Like, we don't have evidence that suggests that doing hip thrusts prior to squats makes people squat either have a better bar path, better bar velocity, they can lift more weight. We just, that data it's not there. We only have data to the contrary suggesting that if you move squats, for instance, later in the training session, that you do worse. Mm-hmm.
Which makes sense. You're fatigued.
Yeah, it was published in the journal, and it's like, no. So my standard recommendation for warm-ups, if your first movement is squats, I would squat. Mm-hmm. That, so for me, that ends up, I go into the gym, I put the bar on the rack, I start doing whatever rep scheme I'm supposed to do. I do that with the empty bar. So if I'm doing sets of 6, I'll do a set of 6, the empty bar, and I'll probably do that 4, 5, 6 times, however long it takes for me to feel like, okay, I'm ready to actually start my workout now. That's what I do. Some people will need to start with a bodyweight squat. Some people who are maybe even more conditioned, who are deconditioned, let's say they're only going to work up to 40 kilos on the squat. They might start with a leg press or an assisted squat or something, or a partial range of motion to get. You want the muscle tissues to be warmed up, so it decreases the viscosity within the muscles. You want the central nervous system to, become more aroused. You want people's, sympathetic nervous system to kick in, so they're more focused on the task at hand. All these things to occur, right? And it takes some time. So, whether it's 10 minutes, 5 minutes, 7, whatever, it takes some time, a non-zero amount of time to do that while you're practicing your skill, which is what I would have them do. If it's a goblet squat with a kettlebell, all right, that's fine too, but I think there's a line where you get away from the whatever you're warming up for, that it just stops being useful. Mm-hmm. And starts just being a distraction. So that would be foam rolling, I think, is a waste of time, again, for all those reasons we talked about. I think that stretching is a waste of time, again, doesn't improve outcomes, doesn't reduce injury rate, doesn't improve performance, doesn't really improve range of motion in the in a non-specific way, meaning that if you do the splits, you'll get better, and practice the splits, you'll get better at doing the splits, but it won't make your squat any better. Yeah. Because the mobility that you've gained, which is a neurological phenomenon, basically allowing you to relax more, the mobility that you've gained is only in the configuration of doing the splits. It's not the squat. So stretching is specific, same way that strength is specific. For instance, if your squat goes up a bunch, right, your full depth below parallel squat goes up a bunch, I don't know how that's going to affect your ability, your broad jump ability. No. I have reason to believe there's some transfer, but I know based on current evidence that the half squat carries over better to that than that to the broad jump than that. I know that hip thrusts carry over even better than that to the broad jump. I know that Nordic hamstring curl, all these things carry over better to that specific task because the joint angles are more similar, the muscle lengths are more similar, the contraction types and velocity are more similar. All these things being more similar makes it transferable better. Same thing with stretching. Like doing the splits is non-specific to the squat, bench, deadlift, press. So if your idea is, I want to improve my mobility for the squat, bench, deadlift, press, well, I would squat, bench, deadlift, press.
Mm-hmm.
And some variations might be useful of those movements, but it's not just doing the splits or like upward facing dog. Is it upward? Downward facing dog. Is there upward facing dog?
Probably. I think it's called the Cobra.
Oh yeah, maybe. Wait, Cobra's is sunrise salutation? I've done yoga. I've done yoga. Only on dates though.
Yoga through YouTube.
Only on dates. That's the state. Like it's a date thing, right? So it's like, oh, do you want to go do yoga, right? And I wish that I paid more attention now because it would come in handy.
Fair enough. But yeah, what you said there is really good because so I used to train out of a CrossFit gym. I didn't do CrossFit. I am not fit. I used to train out of a CrossFit gym, and I would see a lot of people using. Are you familiar with Kelly Starrett?
Oh yeah, the Supple Leopard book. Yeah,
Leopard guy. Yeah.
Sure.
So I saw a lot of people treating the Supple Leopard like it's a Bible, and I've always had the sort of view that like if you've got mobility problems, that you need a book that you could probably beat someone's head in with. Like you probably have got issues that can't be fixed with a book. Like that's like
yeah.
Something serious. But people will say, well, I've followed the Supple Leopard or other similar programs, and I am more mobile, and it's fair enough. But what you said there was, I think, kind of sums it up really well. That if you're wanting to do, for example, CrossFit, and you want to get your mobility to the point that you can do a snatch, once you're mobile enough to be able to do a snatch, you don't need to become more mobile after that. That
Sure.
Additional mobility is wasted training time.
Sure. Yeah. And anything that's not spent snatching or a variation of the snatch or snatch elements does not help your mobility in the snatch. Doesn't help your mobility in the snatch, doesn't help your recovery from the snatch, doesn't help your performance in the snatch. And I would argue that even getting the mobility to do the snatch is best trained by breaking down the elements of the snatch until you can string it all together, right? So it's like if you can't perform an overhead squat to below parallel, and that's like something you need to do, then you could probably perform an overhead squat to just above parallel. Mm-hmm. And then that's where you're progressing down from, rather than doing something unrelated, right? Like unrelated to that, like not doing a squat at all is not going to help your ability to do that. Same thing with the overhead position, right? Like, so exposing yourself to this overhead position with lighter loads, partial ranges of motion, et cetera, would be the way to do that. And that's how gymnastics are trained too. Like it's like this gradual exposure to increased load, increased range of motion, and then eventually they can string it all together. I would agree that if you need a book to tell you how to do this stuff, yeah, it's probably can't be fixed by a book. The more interesting thing I think on that is the narrative, the idea that you're broken and you need to do this to not be broken. That's problem one. Problem two is that you need to do this regular maintenance, like you're a car, which we are not cars. We are not machines. That analogy is bad, right? We are adaptable individuals. Cars are not adaptable, like biologically living things, okay? There's like, there's no amplifier or, or diminisher from us given signal. It's a machine. We are not machines. So the narrative that, you need to do this stuff because you're broken is bad. The second part of that is that you need to do preventative maintenance or maintenance to prevent yourself from getting bad is also potentially harmful, because what if you don't do it, right? And then third reason it's bad is you're wasting a ton of time, right? Yeah. So like in the United States right now, the current exercise guidelines are that people engage in, it's like 3 hour, it's 3 times per week of aerobic training, and then 2 to twice per week of resistance training. And the way I just say it is, you should be doing something every day. It should be the resistance training or conditioning. Okay. How many people meet those guidelines? It's less than 20%, which I think is a even very like generous estimate.
I think it's a bit less than that in the UK.
Yeah. So people are citing time as this huge like barrier, in addition to like lack of access to like places to exercise in general and, whatever. Okay. But one of the biggest things is time. And you want people to spend time stretching? like citation desperately needed that stretching improves outcomes. Because again, if you had this body of evidence suggesting that stretching improved function during exercise, improved reduced injury incidents, decreased, any outcome reliably, like you had a good stack of evidence to say, well, the majority of evidence shows this, then you could make a case for stretching, but we don't. And this isn't something new either, right? So every time something new happens in like medicine or the science at a period, people are skeptical. People are like, nah, that's BS. And it happens for like 5 to 10 years, maybe even a little bit longer, until the amount of evidence that has come out on it is overwhelmingly in support of that thing that previously we were skeptical about. Stretching is not new.
No.
We've been studying this thing 50 years, 60 years, longer. And it's the reason why it's not settled is because people have vested interests and emotional sort of biases that are locked into this sort of stretching model and that biomedical model. And in the biopsychosocial model for pain, injury, and stuff like that, stretching is firmly in the psychosocial sort of realm, meaning that if you believe that stretching is going to improve your outcomes, if you believe that it's going to make you feel better, if the act of getting into the certain stretching positions teaches you to be more, that you're not actually injured or that you're, more resilient than you thought, then that probably, leads to better outcomes. As long as you don't adopt the narrative of, I am a machine, I am like a car, I am broken, so there are a bunch of caveats there. But yeah, people want to call that the placebo effect. Like every different medication or intervention or whatever always has a placebo effect. There's always an aspect of like non-biological functioning that, or non-biological mechanism of action that somehow leads to an outcome. And I wouldn't write that off. It's just that well, one, I just neuralized your whole audience after I told them all this stuff on stretching. So sorry, guys, I ruined that for you. But I think that the problem with the stretching is the associated narrative. And I don't think that I could recommend doing it just for a placebo effect, because I know where people are going to get their information from. They're going to get it from Kelly Starrett. They're going to get it from Athlean X. They're going to get it from, the Move You people. Squat University. And I don't dislike these people as humans, right? I think that most of them are very well educated, but misguided. It's not to say like, I dislike you, you're bad. It's just misguided. And again, this isn't a belief-based system. You can't say, well, I believe, it's like, well, cool. Well, is your belief based on evidence? Show me the evidence. And you're like, well, no, I'm not familiar with the evidence. It's like, well, you're not an expert in this. Then why are you putting out expert recommendations under the guise of being an expert? And then if you don't have any evidence and the evidence only exists to the contrary, then why can't you change your mind? Because if you know that the evidence to the contrary exists and you're still putting out a contrasting message, but all of that, that's called fraud. And I'm not accusing anybody I'm just saying that I don't think that these people are bad. And I don't think that they're like ignorantly putting this stuff out while they know that the evidence exists on the other side. Because I refuse to believe that people are like engaging in this malicious behavior.
Yeah, it would be quite malicious, especially if you understand that aspect of it, whereas like if you believe that you are broken, you will experience pain. Like I don't think these people are trying to hurt people. But I think that's a good thing to include there. It's like we're not saying never stretch. If you enjoy stretching, if you feel better from stretching, then by all means stretch. Just understand the side of it that if you get to the gym and you're 10 minutes late, if you don't stretch, you're not going to break.
No, you'll probably just perform better. Yeah. Well, but I think the other piece of this is, so let's say I met your girlfriend in the gym, right? Not like a weird way, but just like I saw her in the gym.
No yoga classes.
I either overhear her saying something about her back pain or she's telling somebody, right? And let's say I didn't have the skills that I have right now. I was just, your average gym bro, which I feel like I can play that role. I got a hat on, kind of jacked. So I think people inherently want to help other people, right? So I might like dip in and say, hey, have you read this book or looked up any of Kelly Starrett stuff or done this stretch because maybe it really helped me or somebody I know or whatever. Those are the only skills that I have access to or tools I have access to, right? So it's like, if all you have is a hammer, everything looks like a nail. And it's like, these are the only things I know. Here you go. And I feel empathetic because I understand that's how this sort of thing works socially. I would just, again, caution people that, hey, I know you're trying to do good here. I know, but after hearing this podcast, you know, this is a red pill, blue pill moment. Like, you could either take the red pill and understand like things are more complicated and maybe, you know, we should be cautious with what we're recommending, or you can blue pill and everything's the same. I think I got that right. Is the blue pill the truth or the red?
Red pill's the truth, yeah.
Oh, okay, good. I was like, did I mess this up? I might have messed it up.
Right. So one thing that you did mention, I think about 20 minutes ago, and by the way, I'm really cautious of your time. If we're getting to the point where it's like, look, dude, I've got shit to do.
Sure.
Please do let me know. But one thing you mentioned a little while ago with back pain is that there is no evidence that it's predominantly or even partially, correct me if I'm wrong, due to tight muscles.
Correct.
So one of the things that a lot of people will respond to that, and I've heard this response before, is that, well, when I go and get a massage, that helps to loosen my muscles off, and that massage will then make my low back pain feel better. Therefore, the massage sorted out the tight muscles, and that's why my back doesn't hurt anymore.
Yeah, sure. So
how would you respond to that?
So it is true that people who have low back pain will have increased like muscular contraction around the spine. And a lot of that's, we think is due to like protective mechanisms, like fear-based. So like, if I don't move this thing, it'll feel better, like a poor man's joint splint.
Would it be the same in the glutes and places like that? Like
just like it happens like globally, right?
Yeah.
So it's like, and that's not something you're conscious of. It's like it's happening, and that's again not happening in all folks, but non-zero percentage. The massage thing's interesting because people will. It's like discussing something where the goalposts constantly change. So the first thing you say, hey, well, why do you think massages work? And they say, oh, it's loosening my muscles. It's like, what do you mean by loosening your muscles? And they say, oh, well, it's, making them less tight. You're like, you're suggesting that it's increasing, it's somehow altering the, volitional range of motion that you have, due to structural components, like you're decreasing the viscoelastic properties in the muscle that's keep maintaining its length relationship right now, or you're moving the origin and insertion closer to each other to like increase the amount of slack in the muscle. Is that happening? And they're like, well, no, it's it's like increasing like blood flow to the level of the muscle. And it's like, well, no, the evidence on massages suggests that it increases blood flow to the level of the skin, actually potentially shunting blood away from the muscle to some degree. That's because, again, the pressure is on the skin. And anyway, and so then they're like, well, I don't know. I just know that I feel better afterwards. And I'm like, well, yeah, that's perfectly reasonable. You mean you had another human who, without distraction, focused on you for some extended period of time. You had human-to-human contact, likely an empathetic ear. You got to relax in a, in comfortable room. And it probably is a good sort of feeling, That being said, it didn't change anything about the biology. It didn't. All it did was modify how you are thinking about not only how you're thinking, but the other inputs into your sort of pain experience. It's changed your mood. It's, because again, you had this positive experience with another human who wasn't distracted, who's focusing on you. You had human touch, that's releasing certain hormones. Okay. Like that's happening. And then if you had a prior belief that this was going to help you, then you're likely to feel better afterwards. So I'm not against massage. I'm just saying that the massage therapist is unable to identify where there's a tight spot or not. They can't reliably, like if you took 20 massage therapists and asked them to identify where there's an adhesion or a tight spot or a knot, they couldn't do it.
Right.
And where they do think that there is, when you go to image it, ultrasound, MRI, high level diagnostic imaging, there's nothing there. So they can't. And then further, even if let's say that they could identify a knot as something like that, okay, and they place enough pressure, enough friction, enough, force on the skin that ultimately broke this up at the level of the muscle, why wouldn't anything else, any other tissues be harmed? Like if you're pressing on this, like why isn't like there's not any muscular damage, there's not any like large scale bruising that occurs, and so then people are like, yeah, well sometimes when I get like Greston or others myofascial release tools, my skin will be red. I'm like, yeah, you burst some capillaries in your skin, not your muscles. You don't have this huge bruise. Like if anybody's torn a hamstring, no shit, torn a hamstring, like you see this big purple, like nasty bruise. It turns all sorts of colors. You show people, post on Instagram, get sympathy. Like that's not what's happening from Greston. You're breaking some blood vessels, micro blood vessels, and then it's red.
Mm-hmm. Might even bruise, right?
What's that?
It might even bruise. I mean, I've known people who get bruises from massage.
Yeah, but it's not the same type of bruise, and you're not getting low enough and deep enough to even touch the muscle. And again, this is after the fact that there's no evidence that muscular adhesions even exist. Mm-hmm. So it's perhaps the best example of this is acupuncture, right?
Right.
You go to an acupuncturist or a PT who's doing dry needling or something, and they're like, what we're trying to do is take these needles or put them into a spasming muscle or overactive muscle or muscle with an adhesion or some shit like that. And it's, sorry if there's a PG-13, I just get frustrated. But so they try to, some flavor of that. And they're like, we're going to put these acupuncture needles into that and it's going to release. Mm-hmm. Well, there's been a lot of studies on acupuncture, and I'm not saying that acupuncture dry needling doesn't work. What I am saying is that acupuncture with actual needles that penetrate the skin into the muscle or wherever tissue space they do no better than needles that do not puncture the skin, the sham, the placebo treatment. So you don't need to actually puncture the skin. You just need to think that that's happening. What's more is that it doesn't matter where you place them. So for instance, it doesn't need to be at a certain spot in the shoulder. It could just be anywhere in your upper limb, for instance. It doesn't matter. These studies have been done. It doesn't mean, so I'm not saying that acupuncture and dry needling don't work. It's just that it doesn't matter if a needle goes in, and it doesn't matter where the needles are actually placed. Mm-hmm. So there are non-zero risks, for instance, to getting acupuncture. Like you could get a dirty needle. It's low risk, but it is a risk that's there. Puncturing a lung has happened. Puncturing the brachiocephalic trunk has happened. Hitting nerves. All these things have happened. Non-zero risk. And it doesn't matter if you got the real intervention or the sham intervention. So I would pick the sham one. If I'm okay with leveraging placebo if the risk is very, very low.
Yeah.
Right. So yeah, I think to your listeners though, and to other people in this space, if somebody was trying to argue or say that massage worked for them, right? Mm-hmm. And like they really recommend it, I would say, that's cool, man. And just go on living my life. Yeah. Because it's unlikely to be a productive conversation unless somebody's actually curious about, well, is this legit, and then you have to ask, well, what sort of evidence would convince you to change your position? And so if they said, yeah, if you showed me, some controlled trials where people got massages versus controls and they on average did no better, then I would believe you. And you're like, cool, here you go. Mm-hmm. And then then they're like, well, shit, I said that I was going to change my mind. I guess I better change my mind now. But what happens on the internet is that somebody comes in, it'll be like an Instagram post, right? Somebody like, oh, massage is great. You should get massages, blah, blah, blah. And somebody comes in and goes, no, that's BS. Like somebody says that. And then it's like this just, adversarial war. And it's like, that's not worth it.
That's social media in general, though, to be fair.
That's true. Yeah, that's true. Fair enough.
I guess the massage things, and just to put a final nail in this one, I think it's an interesting exploration to the concept of pain as well, because we always consider pain to be like this bad thing. But you can go for a massage and it really hurts, but you'll feel better afterwards because it's almost like cathartic.
Sure, yeah.
And I guess that's... No, you go.
Oh, no, I think that, again, whatever your expectations are of what a massage should feel like influence like how you respond to that and what your expectation is of if it's likely to work. Now, people don't always have conscious, or they're unable to like describe these things consciously, so you may not have insight into what has been your understanding of how massage works and what are the likelihood that it does work and like how it should feel and like the cultural norms and your sort of experience. Like you just don't have access to all of that. A lot of this is buried in your subconscious, right? So somebody could say like, I actually didn't think it was going to work, and then it did. So take that biopsychosocial model. It's like, well, you might not. I've had these conversations before, right? So yeah, just because you don't have access to what sort of psychosocial levers are being pulled doesn't mean that those aren't being pulled. And a further kind of support of that model and that sort of explanation of massage is that if we know that nothing biologically is changing, meaning that we've done pre and post MRI, ultrasound, CT, X-ray, whatever test to identify like, is the spine still in the same position, like disc-wise? Is there any like muscle adhesion we can identify? And if so, like have they been like broken up or released or whatever, verbiage you want to use? And if the answer to all that stuff is no, we have not found any like biological difference like pre and post. Okay. Then that something else is going on, and it's likely psychological or socially based. And so the biomedical model would be unable to describe this phenomenon. They would say, well, we just haven't identified the biological thing yet. It's like, okay, but they're like, what else? Where else are you going to go? So people will say, in that line, they'll say, well, what about like, you said that muscles can be, co-contract, you can have tightness around a joint, sort of like this joint splint thing, increased activity. And sure, there are studies showing that the EMG, the electromyograph activity of muscles, when somebody has low back pain, and some people can be higher than when they don't have back pain, and that after massage that you can see a reduction in EMG activity. And so like, see, boom, there's your biological sort of mechanism. You've reduced somebody's nervous system, like baseline activity.
Of the muscle, yeah.
Sure. And it's like, yeah, but how did that happen? It happened via output of the brain. Mm-hmm. You've manipulated something in the person's either understanding of their pain, their ideas about their pain, their something within the biopsychosocial model, and I would argue in the psychosocial component of this, has been modified that ultimately changed that output. Mm-hmm. It wasn't that the practitioner like pressed on the nerves, like got down in there, got into your cerebellum and your brain stem and like was weeding around and was like, oh, primary motor cortex area, cool, I'm just gonna like massage this guy here and then reduce the neural drive to those tissues. That's not what happened. Rather, again, the person's comfortable, relaxed. It's somebody who's giving them undivided attention, human touch, clinical theatrics, like, oh, I'm going to really press hard here, right? Oh, that's got to be more useful, right? And then all of those things kind of influence the brain's output. So that's kind of how I think about massage. Do I get massages? Again, only on dates. That's the only way that I'm going to get a massage if I gotta go on a date.
I guess if someone does go and get a massage and they feel better and then they go to the gym and they move with full range of motion and they feel confident in it,
that's a win.
Yeah, then they're going to feel better over the long term, and they'll probably will reduce any pain that they had because they're moving properly.
Yep, that's a win. And as long as the narrative being like promulgated by the massage therapist isn't like, you were broken, you had all these adhesions, these problems or whatever, and you need me to fix them, I'm cool with it. Mm. Same thing as like recommending people to a chiropractor. Like, I'm okay with people see a chiropractor, right? Even if they do get an adjustment, as long as the chiropractor is not like, oh, this was out of place. This is out of, I need to fix this. You need me to fix this. Come back every week or every couple of days.
Yeah. So it's funny how that one works out, isn't it? If we've got any massage therapists who are listening, and I believe we probably will,
Sure.
how could they sort of modify their message to be more productive? And are there any resources you would recommend that they check out? Because obviously this one podcast will get you started, but you're not going to change your entire practice from an hour of a conversation.
Yeah. So I think the Pain Science blog is probably the most accessible, like if you're not like clinical research or like, and it's well written and it's open source, meaning that you don't have to like go behind a paywall. So the Pain Science stuff on anything back pain related, for instance, if you're interested in that, shoulder pain, I mean, there's just different sections, and I would just comb through that stuff. It's a really great resource. So painscience.org, and I think there's just get you started. And yeah, I don't want people to be mad at me and be like, this guy's pain. He's yeah. And it's not, again, I don't think they're bad people or they're uneducated or anything like that. It's just, you can only describe the way something works and the whys and hows via the mental models that are available to you. Mm-hmm. If you are not familiar enough with the biopsychosocial model and all these different aspects and nuances of pain, the pain experience, etc., then you don't have access to describing it in any different way. So it doesn't mean that someone is uneducated or anything like that. It's just, it means that they're using the tools that they have to describe the world around them, which is what humans do. So I'm not mad at these people. It's just saying like, hey, I'm presenting you with, again, the red pill. Like, take the red pill, like, come play with us. Like, the water's fine. Come on in. Yeah.
So how could they sort of adjust the
message? Sure. Yeah.
The language to their
yeah. I mean, I don't actually know if there's any clinical. I don't know if they feel compelled to be like, yeah, I'm doing this right now. Like, I'm releasing this muscle. Oh, this is so tight. This is the tightest I've ever felt. Or, oh, you must lift a lot of weights, because it's almost like it's like the waitress at the restaurant. They're like flirting with you low key, but about your anatomy and not like your,
like when you have blood taken and they go, oh, you've got lovely veins.
Yeah, exactly. Which, may or may not be true. It's just like, it's like giving you some like social credit. They're like, hey man, you're looking good from back here. I don't know. I just wouldn't say anything like that. You could have a casual conversation, and it's probably likely to be small talk until whatever, because if you don't know the person. But I don't think I would mention anything about somebody's anatomy or if they're tight or if they have an adhesion or if what you're doing. Just do your job and talk about something else, because again, building that narrative around this biomedical model, I think, does more harm than good. Yeah. I made this joke last night and I really like it. Maybe it won't land with your group, but it's, if you have a chiropractor or a PT, so you have a personal chiropractor or PT, you have a bad chiropractor or PT, because you shouldn't have one. Yeah. Like if you go to see a good chiropractor, you should only see them once, maybe twice, and then they should be building your self-efficacy, giving you the tools that you need to succeed and go on. Yeah. Right? If you have a chiropractor that you see regularly, you don't have a good chiropractor. If you have a PT that you see regularly, you don't have a good PT. Unless you've, for whatever reason, had repeat surgery, like in rapid succession, where you need to go, see somebody to range you or help you otherwise. But if you see a PT regularly for like preventative sort of stuff, you don't have a good PT.
PT, what?
Oh, physical therapist.
Yeah. That stands for personal trainer in the UK.
Personal trainer. Yeah, sorry. So yeah, so you would only see a physical therapist like post-operatively or post-procedure, or like something where you actually need somebody else to help you exercise, like because you can't physically do it yourself. But again, they should be building self-efficacy, changing the narrative, giving you the tools you need to succeed. And bye, Felicia, you're on your own. But on the other hand, if you see somebody regularly and you're doing it for maintenance or preventative, then you don't have a good one. Yeah. So you might know one, but if you personally have a chiro or a PT that you see on a regular basis, you don't have a good chiro or PT. Shots fired. Find me on Instagram.
We're going to get some hate for that. So
I probably got about 10 minutes left where I gotta bounce out of here.
All right, cool. In that case, I've got a few more questions, and we'll just do them sort of rapid firing.
Sure.
A large part of what I see you write about is about programming and the way that exercise programming can be done more effectively.
Sure.
So to just park the pain thing for now, when it comes to working out how you are going to program your exercise, say you've got a general population person, they are reasonably fit and they're wanting to build some muscle. What are the most common sort of mistakes that you see made by novices first and then potentially intermediates? And
Sure.
it might be useful to define those two terms before you, like how you're using them.
Yeah. Well, so it's interesting. We've probably gotten away from using like discretely try to classify folks based on their training history outside of like, you can either use untrained or trained, which is soft, or we use like beginner and then like trained, only because there's a spectrum, right? And so I think like trying to like, there's no use to like categorizing people like novice, intermediate, advanced, because it doesn't change your management specifically. Meaning that if you identified as an intermediate lifter, what everybody else called you an intermediate lifter, I wouldn't know how to program for you any different than if you were a novice or advanced. I could only do that retrospectively by looking at your results and then modifying from there based on your individual response to the program. So anyway, we just use beginner and, trained. That's our, or non-beginner, whatever. So the biggest mistakes that I see beginners make is trying to hyper specialize. So it's like a beginner lifter. They literally have been lifting for, a month or something. Like, I'm a power lifter. I'm like, oh, cool. Like, you already did a meet? And they're like, well, no, like I'm going to do a meet. Like, I just want to get strong enough to do a meet. And I'm like, hey, I'm all for you competing. Like, I love powerlifting. Like, it's cool. Sign up for a meet as soon as possible because they're fun. It'll get you hooked. But you don't need to make all the compromises that a powerlifter has to make in their training to be the best powerlifter they can be. Because by definition, if you are a competitive powerlifter, that's what you're trying to do. So for instance, you could do more conditioning. You could have a higher exercise and rep range variety than somebody who's actually focused on powerlifting, who would do most of the stuff around the squat, bench, deadlift, right? And not the press. And then most of the stuff would be, they do a lot of singles and they have, sets in that 3 to 6 rep range. And that'd be most of programming. If you're not a powerlifter, you don't need to do that. Mm-hmm. And I would argue that it's actually hindering your total physical development as just a human if you did that. And if you're not a powerlifter, why do it? So hyper specializing either in exercise variation, exercise rep range, I think is a mistake early on. So I would encourage more variety. And then I think the second biggest problem that I see, and this applies to almost everybody, is that the elements of autoregulation are being used, meaning that you're going into the gym and you have a weight written down. Mm-hmm. And instead of that just being like a target, you're just like, that's what I'm doing today for this many reps. And it's like, okay, well, the idea of you writing down that weight was based on previous training and the idea that this weight's going to generate the training effect that you want it to generate. Strength, hypertrophy, whatever. Like, that's, otherwise, why write it down? It doesn't make any good. It doesn't make any sense. If on that particular day, your performance level is way, way down, let's say you were up all night because you broke up with your girlfriend, not you. I feel like we've talked about your girlfriend this whole thing. I apologize. But, they're just, you lost your job, death in the family, whatever, but you're still training because what are you going to do? Not train. Or conversely, if your performance was way, way up because, you've realized some previous fitness adaptations, you're having a great day, the girl that you like, agreed to go on a date with you, you're on cloud 9, then that number is wrong and will not provide the correct training stress. It'll either be too heavy for you to either complete the work or to impart the appropriate training stress on the individual because their performance level is down, or it'll be too light if your performance level is way, way up. So having an adjustable scale to sort of move things up or down based on your performance, I think is useful. We use RPE, rate of perceived exertion, for that. You could use reps in reserve. I think both tools are equally valid. You could also use objective metrics like bar speed if you actually had something to measure that. But, in practice, we use RPE or reps in reserve. as a secondary point to that, people aren't using their auto regulation at all to like tell them how much volume to use, or in the case of hypertrophy, reps to do. So let's say that somebody was chiefly interested in getting jacked. I want to get jacked. I'm like, all right, cool. So the idea would be, for most movements, you need to go to like 2 to 3 reps shy of failure, thereabouts. And so they're like, yeah, but how many reps? And you're like, well, it doesn't matter, because the load, whatever load you choose, just do that exercise with that load until 2 to 3 reps shy of failure. Now, in general, I think you're going to get a better bang for your buck if you're, in that sort of 6 to 15 rep range, 6 rep to 15 rep, compared to like 1 to 5 reps, or compared to like 16 to 30 reps. But, whatever. You could argue a bunch of different points in there. But I think the biggest bang for your buck comes from 6 to 15 reps. And then from a hypertrophy standpoint, as long as you're going to like 2 to 3 reps shy of failure, it doesn't matter how many, is it 8 reps or 10 reps? It doesn't, or was it heavier or lighter? It doesn't. It just, did you get to that 2 to 3 reps shy of failure? So using that auto regulation to kind of help you gauge that is useful.
I find some of my clients struggle with that. So if we've decided, if we are programmed it today, we're going to do 5 sets, and I see on the 3rd set that the bar speed is slowed to like snail's pace, they'll be like, right, you're done.
Yeah, exactly.
You've done enough today. And I think it takes a while before that sort of sets in. We'll finish novice or beginner.
Oh, shoot.
I'll let you
go. Yeah. So I think that was pretty much if you're not using auto regulation, then you never get to the correct either loading or volume needed to actually engage in progressive overload, meaning that you have set reps and sets and weights all fixed. It's not that it's a bad recommendation. It's just incomplete, right? Because you don't know like how to, like, what to do if something is changed. And so just like you in person, you just said, like, if the bar speed slows down, or if it's super, super fast, you're going to adjust things on the fly based on your coaching knowledge, which is not, it's evidence-based. It's also experience-based. And you're like, I'm going to make these predictions based on what I know. On a written template, somebody's just following that, which is fine. You need to have this sort of range that you have access to. So should you do 2 or 3 sets for back off? And it's like, well, it depends. On a good day, maybe you should do 3 sets. On a bad day, maybe not as many. On a good day, maybe you should use more weight. On a bad day, less weight. And so using this auto regulation stuff is not only better from like a training outcome, hypertrophy strength based thing, but also from an injury prevention standpoint, because you're never really jacking up that acute on chronic workload to a untenable amount. Mm-hmm. Contrast that to like, here's the weight you're going to hit today, here are the reps and sets. And it's like, that's not always going to work. If it did, so what's your best squat right now in kilo?
My best squat right now is about 195.
Yeah, so 195. And so you, on paper, you're like, what I'm going to do is just add 2.5 kilos every week. Every time that I squat, I'm just going to add 2.5 kilos. And so, 50 weeks from now, so, a little bit less than a year from now, you're going to be squatting 290, 295, right? That's how it works. That's how it works. Oh, wait, that's not how it works for anybody. Like, if that's how it works, we'd have so many great squatters, but that's not how it works. Yeah. And I would argue that the idea that you just add a little bit of weight and that's the, only thing you should be focused on is short-sighted and only going to last for a short period of time anyway. People call that the novice effect, but what I call that is you're just realizing the existing fitness adaptations that you have, whereas developing them takes a much longer time. So you need to have these elements of autoregulation for not only outcome improvement, but also for like injury prevention. So for the novices, hyper-special do. And I just wouldn't hyper specialize in general unless I had a good reason to. And then for like post-novice training, I think that having auto regulation, those are the 2 mistakes I see being made most often. I mean, there are other things, but those are the probably 2 most egregious ones.
Awesome. All right, Dr. Feigenbaum.
Hey.
No, that was awesome. Like, really cool. There's an absolute metric ton of useful shit in there. So I hope the listeners have really enjoyed it. I hope you're taking a lot from it. Tell me where we can find more from you, where we can get some more of your content. Where can people find you on the internet?
Sure, yeah. So our website's barbellmedicine.com. YouTube channel, you can search Barbell Medicine. We've got a bunch of videos up there. You can find me on Instagram. I'm pretty active. It's Jordan_Barbell Medicine. And then the rest of the crew, all of them have the Barbell Medicine like thing tag at the end. So you can find all of us if you just search on the gram. You'll find us there.
Yeah, and seriously do that because their content's awesome.
Hey, thanks, man.
So well, there we go. So if you've enjoyed the show, if you think that anyone would benefit from listening to it, or if you think you could annoy a massage therapist by sending it, please do share it around social media. We'd absolutely love to hear any comments, any feedback that you've got. If you haven't done already, please do leave us a review on iTunes. We always do really appreciate that. And if you'd like to get some more from us, please remember that we do have a conference coming up in April. So if you'd just like to head to our website, you can find more details around the conference. Alternatively, you'll find some of that on the Facebook page at BTNacademy Nutrition Education. So one more time, Jordan, thank you very much for joining us.
Hey, thanks for having me.
And for all the listeners at home, stay awesome.